shout out to Drs. Hernandez, Satsu, and Jeannie for helping with my presentation. So our to-do list today, we're going to talk about renal resuscitation and trauma. We're going to talk about staging renal injuries and trauma. We're going to talk about what exactly conservative management of renal trauma entails. And this is important because usually if we use a surgical option, these patients more than likely will get nephrectomies. We're going to discuss some complications of delayed surgical intervention. We're going to talk about other GU injuries as well, just briefly. So for general GU trauma, prevalence amongst all traumas are about 1 to 5%. Renal accounts for the lion's share of this, with 2/3, followed by bladder, with urethra and ureteral injuries being a little less common. Mortality directly due to renal injury accounts for less than 3% of all trauma mortalities. But there's a higher incidence because usually there's like polytrauma and multiple intra-abdominal injuries. And because it's high mortality, obviously management of the head and torso takes precedent. When you're working up the GU system, generally you'd like to go in a retrograde manner. You want to start with the urethra, end up in the kidney. But for the sake of this lecture, we're going to start with the kidneys and focus on the kidneys. Note about 10% of blunt injuries, renal injuries require surgery versus 50% of penetrating. So let's start off and discuss a potential patient. Let's say he's 53, he's been by EMS for an MVA, his vitals are normal, patient's complaining of a little bit of flank pain. We get a closer inspection and we see that, a little bit of gross hematuria. So it's suffice to say we're still going to stick to our ATLS protocol, IVO2 monitor. We're going to focus on our ABCs. We're going to think about imaging. The indication for imaging in renal trauma specifically is usually gross hematuria, microscopic hematuria with shock. Major associated injury, high index of suspicion based on mechanism of injury, and penetrating traumas. We're always going to have transfusion in our armamentarium, just like any trauma protocol, and damage control surgery is sort of the last ditch effort in renal trauma. So we go and we get our imaging, we get our son at the bedside, we do our FAST, we look at the renal windows, and we look at both sides and think, oh, the kidneys look perfectly fine. So despite this hematuria, this patient's probably fine, but not the case. Generally, FAST is great for intraperitoneal bleeding, of course, but you guys should know that there's a very low sensitivity for RP bleeds. So the gold standard is always going to be CT for renal trauma. So we get a CT, this CT in particular, shows a grade 5 renal injury. So just to clarify, this is not our patient, but this is just an example of really high grade renal injury. But when radiology calls and says grade 5, we're thinking, what does that mean exactly, grade 5? So the American Association of Surgery of Trauma came together in 1989, and they developed this injury severity scale. Scale goes from 1 through 5. One's a minor injury, which is basically just a contusion, or a subcapsular hematoma, non-expanding. Grades 2 and 3 are lacerations that vary in depth, either less than or greater than 1 centimeter. Grade 4 is a laceration extending into the collecting system, or any injury any vascular injury. And grade 5 is essentially a shattered kidney, which involves injury of the renal pedicle or avulsion of the hilum. Usually grades 1 through 4 in blunt trauma can tolerate conservative management, and grades 1 through 3 can tolerate conservative management in penetrating injuries. I just want to give you a quick graphic, try and get an idea of what these look like. Grade 1, you can see the contusion. 2 and 3, you see the lacerations in varying depth. Grade 4, the involvement of the collecting system, and grade 5, the shattered kidney. So moving back to imaging, so apart from sono and CT, one of the mainstays of imaging in renal trauma is the IV pilogram. It's not as significant for us in the ER, but in the OR it's significant. So these patients will go to the OR for potential XLAP due to polytrauma, but oftentimes the surgeons are going to want to know, is there any renal injury involved? So they get a one-shot IV pilogram, and they can determine if they need to advance into the RP space and do renal restoration. If you look closely at this image, you can see that that it's patent on the left, and it's the nephrogram is completely absent on the right. So if we go back to our patient, he gets a CT. CT is negative. The vitals are stable. He gets some morphine for pain, but what about the hematuria that we noted? So just a little bit about hematuria and renal trauma. So patient complaining of flank pain with no hematuria doesn't preclude renal injury, although it is present in the vast majority of these patients. Gross hematuria requires monitoring all patients. Microhematuria doesn't correlate with the degree of renal injury, and usually you want to place the Foley to monitor clearing of hematuria. So our patient in this case likely had a contusion grade 1 injury. That's why it wasn't really picked up in the CAT scanner. So I was going over some of these guidelines. I noticed that like Australia had some guidelines, the EU had some guidelines, but at the end of the day we're in the US, so I focused on some American guidelines. So I pulled up this paper by UCSF discussing their algorithm for renal trauma. So first, in adult blunt trauma, they like to break it down between microscopic hematuria no shock versus gross hematuria with shock, gross hematuria or microhematuria with shock. For the microscopic no shock, generally these patients don't need imaging and they'll just be observed. For the gross hematuria or the microhematuria with shock, we break it down to unstable and stable. Unstable is obviously we'll go for the XLAP, get the IVP, potentially get renal exploration. The stable patients, always patients who require CT scan and plus minus an IVP. And depending on additional injuries, they may require renal exploration plus lap. If there aren't any associated injuries, you can sort of tease it out based on grade. Low grade 1 or 2, these patients will be observed. 3 or 4, these patients will be it'll be clinical judgment whether or not they need to go to the OR, and grade 5 generally go to the OR. For pediatric blunt trauma, it's broken down initially between stable and unstable. Unstable, again, XLAP, IVP, potential renal exploration. Stable is broken down between minor or moderate or severe trauma. So minor trauma is obviously no obvious deformities, just some pain. And these patients are broken down further into micro or gross hematuria. So if you're minor plus gross hematuria or moderate and severe, you automatically get imaging. If you're minor with just microscopic hematuria, again, you're just going to observe. If the hematuria worsens, then those patients require a CT scan. And then the algorithm sort of reverts back to our adult algorithm. Additional injuries potentially warrant renal exploration. No additional associated injuries. We go back to low grade observation, moderate grade, then the clinical judgment, and high grade renal, oftentimes renal exploration. So adult penetrating renal trauma depends on the location of the entry and exit wounds, if they're within the path of the kidney, or if there's hematuria, then all these patients automatically get imaging. If they're unstable, that's going to be our XLAP IVP pathway. If they're stable, despite whether or not there's suspicion of peritoneal penetration, they're still going to get the imaging, as I mentioned. And then, again, it reverts back to low grade of observation, moderate grade clinical judgment, and high grade renal exploration. So that's great for UCSF, but I just wanted to find something a little more universal that's longer than I remember. So I went and found guidelines of guidelines. So this was actually published out of Australia in 2015. And what they did is they looked at 3 major urological associations, one being European Association of Urology, the American Urological Association, and then the Société Internationale d'Urologie in French Canada. And then they took a composite of all their recommendations and they graded them based on class. So remember, grade A recommendations are strong RCTs, grade or exceptional observational studies. Grade B are weaker RCTs or like okay observational studies, and then grade C are just weak observational studies. So some of the recommendations, so patients with gross hematuria should undergo abdominal pelvic CT, and this is grade A in the US. Stable patients will get conservative management as long as they're low-grade injury, grade B, in agreement across the board. So this is where things sort of differ. In the US, we say initial conservative management for high-grade injury. So if you have grade 4 or 5, you should consider conservative management prior, rather than going immediately to the OR. French Canadians say surgical repair if they're already getting an XLAP for grades 3 or 4, or XLAP automatically for grade 5. And Europe says renal exploration only for vascular grade 5 injuries. They're all in agreement that unstable patients should get an XLAP, but you consider angioembolization as an option. And then angioembolization as a first-line option for active bleeding with no indication for open surgery is a European recommendation. For renal vascular injury, only attempt revascularization in patients with solitary kidney or bilateral renal injuries. Again, French Canadian. And then agreement across the board, all these patients should get follow-up CT for high-grade injuries within 36 to 72 hours after presentation. And patients with renal trauma should have some periodic blood pressure monitoring, because if there's renal ischemia, you have activation of the RAS, and obviously there'll be hypertension. So what exactly does conservative management entail? It's simpler than it sounds, or simpler than it seems. So it's really observation, reassessment, serial H&H in case there's an expanded hematoma. You want to think about thromboprophylaxis. But thromboprophylaxis in renal trauma, you want to think about, especially if the patient's younger and it's isolated renal trauma, consider venodynes or intermittent pneumatic pressure cuffs rather than anticoagulation, because obviously you want these patients to be able to clot off if they have a slow bleed. Bed rest until resolution of hematuria. You consider antibiotics only if it's grade 4 or 5, meaning a collecting ductus injury. There was a study with grade 4 injuries that showed that patients who weren't giving prophylactic antibiotics, about 5% of those patients required nephrectomy for sepsis. So the rationale is prevention of UTI or periodic abscesses, which can occur in about 10% of the population. We've already mentioned repeat abdominal imaging at 36 to 72 hours. And then discharge criteria, obviously patients can't have any hematuria if you want to send them home. They should be ambulating, voiding normally, and timing for return to activity. So they shouldn't be engaging in any strenuous activities initially. Paper chase. I just wanted to go look at some more current literature, because renal trauma doesn't really change too much, but I just wanted to find some papers that supported conservative management. The first paper was out of NYU. It reviewed like thousands and thousands of papers. We found about 20,000 cases for renal trauma, and found that non-operative management in the first 24 hours scales of only about 2.7%, which is pretty promising. And they suggested some predictors of failure of non-operative management would include renal injury grade, as in like grade 4 or 5, non-renal abdominal injuries like splenic, etc., or penetrating injuries. I found this is kind of an interesting paper talking about trying to predict what kind of MVAs would be more likely lead to renal trauma. So what they did, this is in Seattle, they basically had a crash team go on site to all of these areas, like all these MVA scenes, and they would look at like skid marks, they would look at the damage to the cars, and primarily look at vectors, and then they would try to anticipate what vectors would more likely lead to renal trauma. So they looked at, they found that basically the frontal vector and lateral vector on the driver's side were more susceptible to renal trauma. Basically, it would be the steering wheel or the seatbelt in frontal, or intrusion of the compartment about 30 centimeters on the lateral driver's side. So, and then this was an interesting paper out of France. So this was basically solely high-grade 4 or 5 injuries, and then they found they were trying to predict some, again, failures of non-operative management. Some of the hints or some of the things you can look for are deceleration mechanism, associated lesions, like a percentage of devitalized parenchyma greater than 25%. If a patient gets angioembolization, if there's hemodynamic instability or low hemoglobin, these were patients that were more likely to need surgical intervention. But only hemodynamic instability and high grade were independent predictors of surgical treatment. And then I found this last paper similar to the prior, which was done at like 12 level 1 or 2 trauma centers in New England. And they basically took 200 patients, About 50 of those patients automatically went to the OR. The remaining 150 had non-operative management. These are all high grade 4-5. And of those 150, there was a 6.5% failure rate, so that's, again, still fairly promising. They said about 77% of all patients, including the ones that went to the OR, had renal viability after their intervention, and then about 90% of patients that were solely non-operative management had retention of renal function of the damaged kidney. However, between grades 4 and 5, grade 4, the damaged parenchyma was recovered in only about 40% versus grade 5. The damaged parenchyma wasn't recovered. And they also had predictors of failure of non-operative management. So this included ongoing fluid or blood resuscitation, associated abdominal injuries in age greater than 55, as well as worsening acidosis. So we're thinking about non-operative management, but we should probably think about some of the complications that we can anticipate if we're not really going to bar with these patients. So some of the more common complications include urinary extravasation. I know this is a picture of the bladder, but the more common, actually most common indication of renal extravasation is the kidney. Basically, you get damage to your calyces or your renal pelvis, and then blood will leak out to the RP space. It'll interact with your RP fat pad or your perinephric fat pad, cause lipolysis, and you get like a pseudocyst, causing what's called a urinoma. And basically, that urinoma can lead to sepsis or abscess, so those are usually drained. You can also have infection, you can have delayed hemorrhage, you can have devitalized renal segments, as I mentioned, hypertension, renal insufficiency. So I'm just going to quickly touch on the other systems. So for urethra, generally these are going to be due to blunt trauma. Fairly rare in women. Symptoms include peritoneal pain, inability to void. Some of the signs are gross hematuria, blood epimeatus, peritoneal swelling, ecchymosis, absent body, hyaluronic prostate. And they can be anterior or posterior based on relation to the ureteropelvic diaphragm. So anterior usually due to straddle injuries. Anterior injuries are kind of interesting based on their relation to Buck's fascia. If Buck's fascia is intact, it'll limit extravasation in urine near the urethra, to near the urethra. But when the fascia is interrupted, this extravasation will go into the scrotal sac. It'll go into the anterior abdominal wall. So if you see like fluid developing in those locations, you may consider a urethral injury. Whereas posterior urethral injuries generally are associated with pelvic fractures and bladder rupture. As you guys recall, retrograde urethrogram for diagnosis. You can see extravasation in the urine. So management is always going to be urology consultation. You don't want to attempt catheterization unless you're doing it in conjunction with urology. And always, it's going to be gentle passage. If there's inability to void or disruption, complete disruption of the urethra, you're going to get a suprapubic. You're going to want a suprapubic cystogram. So bladder injuries, again, most likely to be blunt. Secondary to MVAs, 2/3 are due to pelvic fractures or associated with pelvic fractures, and only about 5 to 10% are associated with urethral injury. Patients will have suprapubic tenderness, inability to void, gross hematuria, and it'll be either extraperitoneal or intraperitoneal. So extraperitoneal accounts for about 2/3, and the injury is limited to the pelvis, usually the anterolateral neck wall at the neck of the bladder. They're treated with catheter drainage or observation. Intraperitoneal accounts for the remaining third, and a third of these are also associated with extraperitoneal injuries. And this is primarily the fundus or posteriorly, and these are usually repaired operatively. Quick image of a cystogram. You can see extravasation, so you want to use a water-soluble contrast. You want fluid to stent to prevent any false negatives. Quick CT cystogram. Highly accurate. The advantage is obviously unnecessary additional radiation or cost of getting a separate cystogram. So ureter injury is going to be the rarest of GU injuries, usually iatrogenic. Can happen in trauma secondary to penetrating injury. Can happen with blunt trauma, but it's usually UPG avulsion, and that's more common in children. You can have microscopic hematuria in a lot of these cases, but some cases will have no hematuria whatsoever. The signs and symptoms of this injury is obviously going to be obscured because it's more likely to be polytrauma. CT scan to confirm, and these are repaired surgically. Just a quick look at what that would look like on CT. So lastly, the external organs. So scrotal injuries, usually like a laceration, or given that the scrotum is has very redundant tissue and has very dense vasculature, makes it appears easy, but you should also consider an ultrasound in these patients. I think that's probably seems like common sense. With the testicular ultrasound, you're looking for rupture. About 90% of ruptured testes can be salvaged within the first 3 days. For penile injuries, if there's a complete amputation and it needs to be repaired within 6 hours, impotence is common in these cases. You want to exclude urethral injuries before repairing lacs. For vaginal injuries, usually from a straddle mechanism or secondary to pelvic fractures, these patients require additional examination to rule out any vulvovaginal communication. You want gyne consultation for any significant injuries and antibiotics for penetrating injuries and open pelvic fractures. That's it for non-operative. So in summary, on my part, most renal traumatic injuries can be managed conservatively. Patients with microscopic hematuria should be observed. Gross hematuria, additional injuries to shock or CT. High-grade renal injuries, angioembolism should be considered rather than just jumping to the OR. Antibiotics for grade 4 or 5 renal trauma, DVT prophylaxis should be tailored to severity of condition. Mechanisms, remember, vectors may help you predict if there's renal injury. Ongoing transfusion, H355, acidosis-associated injuries may warrant surgery, in addition to high-grade hemodynamic instability. So with that, I think we're going to talk about surgical management.